bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. It's great to be back. I was away for a while between vacations in Canada Day and everything else. And thanks to Lisa Stromquist and Anne for filling in last week while I was away as well. So I'm glad that all the webinars went off well while I was gone. Today's webinar is titled Managing Privacy Risks When Building a Learning Health System, and we have two really excellent speakers today. I'd like to thank one of our knowledge translation partners, the CHIO Research Institute, and Adrian Viano in particular for bringing this topic to us and for introducing us to Dr. Khaled El Imam, who I'll introduce in a bit. Because this was such a relevant topic. At CAFC, we're constantly confronted with privacy issues and conversations about privacy around data, whether it's within our own benchmarking and data sharing program, which is known as CPDSN, the Canadian Pediatric Decision Support Network, or whether we're working with members and partners looking to share information or collaborate on research projects across institutions or across provincial and national jurisdictions. It gets very complicated, and the privacy issue is often unnecessarily just a showstopper because we just really don't understand the issues. So, and I love, we'll see if you look at Dr. Anne Kavukian, one of our panelists today, if you look at her bio on our Knowledge Exchange Network, she's got a great statement in there that says she's dedicated to demonstrating that privacy can and must be included side by side with other functionalities such as security and business interests. Her mantra of banish zero-sum enables multiple interests to be served simultaneously, not to the exclusion of the others. So I think that's a great statement that sort of sets the stage for what we're going to be talking about today. So it's my pleasure to introduce the panel, but before we do that, one more item. I would like to mention the 2015 CAFC Annual Conference, which is coming up on October 18th to the 20th. Everyone's invited to join us in Quebec City, where we will learn and share our expertise in finding solutions in children's healthcare. We'll be welcoming Dr. Michelle Boivin from the Children's Hospital in Quebec City, Dr. Stephen Miller from the Hospital for Sick Children in Toronto to talk about the importance of early childhood development and the importance of healthy starts for children and how that's the long-term impacts of that. We'll be having Chantal Petitclerc, Paralympic champion and world record holder, as our motivational speaker, and we're also very excited to bring a program from Cirque du Soleil called Cirque du Monde to do a bit of a performance and a presentation. Cirque du Monde is a program where they use their acrobatics type training to help support children with mental illness and other disadvantaged children. So an excellent conference coming up in October as always, and we hope everyone's able to join us there. So now we'll get on with our presenters. First we'll be hearing from Dr. Khaled El Imam. He's a senior scientist at the Children's Hospital of Eastern Ontario Research Institute, and he's the director of the multidisciplinary electronic health information laboratory team conducting academic research on de-identification and re-identification risk. He was also the Canada Research Chair in electronic health information at the University of Ottawa from 2005 to 2015, and he's an associate professor at the Faculty of Medicine and the School of Electrical Engineering and Computer Science. He was also one of the first Privacy by Design ambassadors recognized by the Ontario Information and Privacy Commissioner. And joining Dr. El Imam is Dr. Anne Kavukian, certainly recognized, a recognizable name for many, I'm sure, and recognized as one of the world's leading privacy experts. She's presently the executive director of the Privacy and Big Data Institute at Ryerson University and was appointed as the Information and Privacy Commissioner of Ontario in 1997 and served for 3 terms as the commissioner. And that is where she created Privacy by Design, which is a framework that seeks to proactively embed privacy into the design specifications of information technologies, network infrastructures, and business practices, achieving the strongest possible protection. So we really have the world's leading experts in this area presenting for us today. So it's our pleasure to hand the virtual podium first over to Dr. Khaled El Imam. Over to you.
Okay, perfect. Okay, well, thank you very much for that introduction. This is Khaled El Imam. So the flow of the presentation today will be as follows. We'll have 3 sections. We'll start off by providing an overview of what learning health systems are and where the privacy issues come in when these types of systems or organizations are being set up. And then Dr. Gavukian will describe Privacy by Design, which is the core approach for dealing with privacy issues, and then I will follow that with a description of one of the key techniques within Privacy by Design implementation, which is anonymizing the data. So there'll be 3 sections laid out as I mentioned. So learning health system, the basic principle with that is you collect data or information from every patient who comes into the hospital or the clinic or the network of hospitals, and the objective is to use all the data about every patient to learn and to accelerate progress in developing better treatments. It's more than just evidence-based medicine. It's really using all the data that's available at every patient to inform our decisions and build better models. And this definition comes from a report by ASCO on learning health systems, which I found to be very, very useful to kind of summarize what we're trying to do here. So a learning health system is not only about using evidence to inform decision-making or decision support systems. In a more traditional sense, you'd have online guidelines that may be triggered at the point of care, or alerts for drug interactions or electronic references that are readily available again at the point of care. So this provides evidence to the clinicians at the point where they need them. So that is these are good things, but this is not really what learning health systems are about. Sometimes there's a discussion about integrating data from multiple care settings, such as hospital, family doctor, pharmacy, and so on, and provide an integrated view to the clinician about every patient when they come in, so they can see basically the journey or the interactions with the healthcare system over time. And having integrated data and access integrated data is very valuable and important, but that's still not what we mean by a learning health system. Matching eligible patients with ongoing clinical trials, when you have a lot of data available, integrated data available, it is possible to match individual patients with ongoing trials by analyzing the clinical data and matching it with the screening criteria for the trials, and then flagging trials that may be relevant for that patient that they may be interested in participating in or willing to participate in. And again, that's important, but that's still not what we mean by learning health system. It's all of these plus the use of historical data from all patients to make care decisions, and I'll specify this a little bit more. So if you have all the data integrated across different care settings, then you're able to do comparative effectiveness research, you're able to do pragmatic trials or quasi-experiments, so you're able to evaluate and compare treatments using observational methods from the data that's available, and learn from all the patients that have interacted with have data about all the patients that have come in, learn from them to compare treatments, for example. You can also do post-marketing surveillance and drug safety studies by analyzing the information, and I'll give you an example of that later on, by analyzing the information about the treatments that received, the drugs that were taken, and any adverse effects that showed up afterwards. Public health surveillance is another example of what you can do with an integrated data set. But also, the ultimate objective here is to compare patients that are being seen today with all the historical data, all previous patients, and find out which treatments have worked. So if you have a data set with treatments and outcomes, short and long-term outcomes, then these can be queried at the point of care to find similar patients or patients that match the ones that are being seen, to find which treatments have worked and what the outcomes were for all the previous patients that have gone through your or other facilities that are represented in the database. And that's really the ultimate objective, is to pull all the data, make it available for these online real-time queries available to clinicians at the point of care to compare their patients with other similar patients to find out what the prognosis was given certain treatments that were provided. So you have up-to-date learning from all previous experiences from all previous patients. And so that's what we're talking about, creating these databases to learn from them. And as you can imagine, that raises a number of privacy issues. And when we talk about similar patients, the matching can be done on multiple variables, including demographic, disease state, treatment history, and genomic information as well. So depending on what information is available in your electronic medical record or has been collected about your patients, they will be compared to this repository of history or repository of other patient information, and that report is produced to show for these similar patients what treatments were received and what the outcomes were. And that's what we mean by a learning health system. The ideal or the ultimate objective, or at least that's how we're referring to it here. So you do the research work, the comparative effectiveness, the drug safety studies, the public health surveillance, which are useful things to do when you have this kind of data set, but also to be able to inform care using the best available evidence. And one of the drivers for this is that we learn from clinical trials typically, but only a very small percentage participate in clinical trials. And so we only learn through the clinical trials process, only learn from a very small percentage of the patients, whereas with a learning health system, you can learn from all the patients' experiences and improve care that way. So when these types of large databases are created representing the history of all the patients, with the short-term and long-term outcomes and integrated data from multiple settings, and of course the bigger the data set, the better. This raises some privacy and ethics questions. From a privacy perspective, as we will discuss throughout, I mean, one of the main mechanisms for addressing any risks there, or the primary risks there, is to de-identify the data, and this will be considered arguably a secondary use of the data, and it's not possible to obtain consent because the types of queries that will be run on that data set and types of analysis are unknown in advance, so it's not really possible to get an informed consent, a truly informed consent, because the uses of the data are unknown at the outset. Therefore, the data will be de-identified and no consent is required in order to use the data under those circumstances if it's de-identified. So we'll spend time talking about de-identification methods. From an ethics perspective, this is interesting and it's a controversial issue, and I'm not going to get into it, I'll just point it out. So some have argued that many of the activities of a learning health system should not be treated as regular research and therefore do not qualify for ethics review because they're not typical research, because they don't produce generalizable knowledge, especially when you are querying the database for similar patients to understand the outcomes and the treatments received and so on. This is not generalizable knowledge. This is decision support, a form of decision support to inform care, and therefore ethics review for these types of uses of the data would not be needed. a form of quality improvement or clinical decision support functionality or system. And this is a controversial view which has folks on both sides of the fence on this, but it's something that would have to be addressed. So for today, we'll focus on the privacy question and what are the privacy frameworks that need to be put in place to collect these integrated databases and use them for informing care for patients, but also to do the comparative effectiveness research. So now Dr. Anke Wupjen will talk about privacy by design, which is the framework that can be used to to manage the privacy risk, and of which anonymization is one of the techniques embedded within that. So now I'll pass it on to Anne.
Many thanks, Dr. Alimam. I'm delighted to be here this morning to join Dr. Alimam to talk about the privacy risks involved. I always say that if you can identify the risks in advance proactively and embed the necessary protections into the design of the technology you're using, then you're way ahead of the game. So let me just start. Whenever I have a captive audience, I always want to talk about what privacy is and what it is not. So let's start there. What privacy is not is secrecy. Privacy is not about having something to hide. This always drives me crazy because I'm sure you've all heard the line, well, if you have nothing to hide, you have nothing to fear. That's nonsense, and it also doesn't reflect a free and democratic society in which we have a right to have freedom associated with the information that we choose to keep to ourselves. So I always say privacy equals control. Privacy is all about personal control, an individual's ability to control the uses of their information, to whom it's disclosed, all about freedom of choice. The Germans have a wonderful term called informational self-determination. Big term, simple concept, that it should be the individual who determines the fate of his or her personal information. Not the state, not the government, not your spouse, but the individual. And the reason for this is because privacy decisions are highly contextual. The decisions that you make relating to certain pieces of information may be completely different than the decisions I would make. And I always use myself in this example because I've spoken very publicly about a lot of the health procedures and surgeries I've had over the years because it has served my interests as a commissioner when I was formerly a privacy commissioner. I chose to disclose my health information because it served a particular purpose. I would never, obviously, suggest that anyone else should choose to disclose their health information, which is, of course, highly sensitive. So highly contextual, that's what's critical about privacy. I developed something called privacy by design many, many years ago, but it really took off in 2010, and that's why I call it the decade of privacy by design. In 2010, the International Assembly of Privacy Commissioners and Data Protection Authorities, we voted and unanimously passed in for privacy by design as an international standard. And this was really a significant development because most commissioners, regulators, are highly wedded to regulatory compliance, which is also very important, but is no longer sufficient as the sole means of protecting privacy. In this day and age of ubiquitous computing and online connectivity and social media, it's just not enough to pursue privacy infractions after the fact once the privacy infraction has developed. My goal through privacy by design was to try to prevent the privacy harms from arising. I wanted to completely eliminate the possibility of privacy harm. And you know, it's a big goal, but you might as well aim high. And the best way of doing that, like in medicine, have a model involving prevention, where you can prevent the harms from arising, and embed the necessary protections into information technologies, business practices, operational processes, right from the outset. Bake it into the system. So this was, as I said, passed in 2010, and since then it has grown dramatically. It's been adopted globally, all around the world, and it's been translated into 37 languages. So we're very proud of this, and I'm telling you, when I was commissioner, not a week would go by that I wouldn't hear from some jurisdiction about how they were implementing privacy by design in some new creative way. Let me give you some of the basics of privacy by design. It's obviously, I talked about it being a proactive model. You have to address the necessary protections in advance. But another key component of PBD is that it is a positive sum model. It is not zero sum. It's not privacy versus health research or privacy versus security. Get rid of the versus. That zero sum model of one interest versus another is highly problematic and I think undesirable. If you can change the paradigm to what we call a positive sum model, and I do apologize for using that language, but when I was in graduate school, game theory was really big, and everybody for some reason was doing research on zero sum. I, being the eternal optimist, embraced a positive sum because then you could get two outcomes instead of one. Isn't that preferable? I mean, surely that's a more desirable outcome. Also, I've talked to so many brilliant technologists and engineers and software designers, and they have absolutely said to me that it is not an either-or proposition, that it's essentially having privacy versus security, for example. That's a false dichotomy involving unnecessary trade-offs. Get rid of that model, replace the versus with an and I can assure you that will open so many doors. This has happened again and again. It's given me a seat at the table where otherwise I would not be invited, because when you don't say no to the other interests involved, you say yes and here are the protections I want you to build in. They're open to that. But you can't be dismissive of the other area, especially in this area involving health research. My God, what could be more important that impacts the health of everyone on the planet? So it's absolutely critical that we do this. And I love that Dr. LMM referred to learning from the data, learning from data sets. That's what I want us to do, especially, you know, I referred to a lot of the medical procedures that I've had, many over the years. I would love for research to find answers to everyone's problems. And in order to do that, we have to access data. Let me run through very quickly the essentials of privacy by design, which I've covered many of them. Proactive and preventative in nature. Privacy as the default setting is absolutely critical. And I should tell you, in the EU, the European Union, they have a general data protection regulation, which will be passed probably by the end of this year, early next year. For the first time ever, the words, the language of privacy by design and privacy as the default actually appear in the regulation for the first time. And that will be an enormous strength for privacy by design. Privacy as the default setting means that the individual involved doesn't have to find the opt-out box and check that they care about their privacy, don't use it for secondary purposes. It means that if you embed privacy as the default, it is automatically available to individuals. Privacy assurance can be guaranteed from the beginning. No one has to fear that their privacy is not going to be considered because it is the default setting. Embedded in design is clear. Make it part of the data architecture. I've talked a lot about full functionality, but it is absolutely critical to this paradigm. End-to-end security, I can't emphasize that enough. While the term privacy subsumes a much broader set of protections than security alone, if you don't have end-to-end security in terms of full lifecycle protection from the time of data collection through data use and through secure destruction of the data, you're not going to have any privacy. It is predicated on extremely strong, solid security. Visibility and transparency, especially in the context of health information, is critical. You have to be open with your practices with the data subject or the patients involved in this case. It is critical that they understand what you're doing with the data and that you have this transparency. And finally, respect for the user, keeping it user-centric is so important in terms of how you deliver the functionalities and how the user understands the protocols involved. So very quickly, that's it. I'm going to give one example in the next 5 minutes, which is what I have left, on the Internet of Things. And you might wonder, why am I talking about the Internet of Things? The reason is because the growth in wireless and wearable devices is just so dramatic, and third-party monitoring can often remove control of one's information from the data subjects involved. And if you recall, I started with my first slide of privacy equals control. Now remember, I'm talking about privacy equals control in terms of personally identifiable data. If the data are de-identified or anonymized or something like that, then it's no longer considered personal information. So the concerns arising with personal information would evaporate when you de-identify the data. That's why it's absolutely critical to consider these measures and use techniques such as aggregation, anonymization, de-identification, etc. Once a year, there's a Privacy Commissioners Conference. Last year, it was in Mauritius, and they issued this declaration relating to the Internet of Things. And among other points, they said that privacy by design should be the key selling point of innovative technologies. And the reason I love that is you can make privacy, especially when you embed it in design, as a selling point of whatever you're doing. Health research is absolutely critical and vital that we have access to data and databases. But you can sell it by saying we follow privacy by design from the beginning. There is no risk to the information involved, with a high level of certainty. I don't have that slide here, but I always tell people the myth, I call it the myth of zero risk. There's no such thing as zero risk anywhere in the world involving any activity. So let's not expect zero risk in this area as we don't expect it in others. However, having said that, you can minimize the risk dramatically, and we'll talk about that in a moment. Just one more thing. In the EU, there's the Article 29 Working Party. They issue a number of opinions. Here's one on Internet of Things. And again, they said make privacy the default setting, follow privacy by design. And if you just scroll to the bottom, these were a number of the other points they made, but they said data should be de-identified except when absolutely necessary. So you'll see that even in Europe, where privacy standards tend to be somewhat higher, the de-identification concept is absolutely critical and should be followed because it enables you to innovate. You can do amazing things when the data are de-identified, data minimization is brought into factor, and it allows you to make the maximum value of the data while preserving the maximum privacy associated with it. So it really is a win-win proposition. And many people have talked about this. Here's a comment from the Information Technology and Innovation Foundation, where they said that re-identification concerns were overstated. Anonymized data can, in many certain circumstances, be used without fear of re-identification. And I think that's where we have to keep in mind the enormous benefits that will result from the use of de-identified data, with the risks being minimized dramatically. You may have heard of some research that has allegedly pointed to the weakness of de-identification and the strength of re-identification. It's nonsense, because when you dissect that, as Dr. LMM has done, you will see that the de-identification protocols that were used were extremely weak methods. If you start with anything that's weak encryption, it's going to be easy to decrypt the data or do a brute force attack. But if you use strong de-identification protocols combined with a risk of re-identification framework, then you're golden. The risks will be minimized dramatically. Here's a paper that Dr. Lem and I did last year, and we talked about the enormous risks of abandoning de-identification efforts, that was just too high a price to pay, and that we can find a better way, which in fact we have. Now I want to end by just referencing two other areas, just for your information. People care deeply about privacy, and these results have been coming out again and again. Recently, there was a study down at the University of Pennsylvania that showed extremely high, in the 90 percentile, concern for privacy, and the fact that people who went online were not prepared to give up privacy in exchange for another, a free service or product. And Pew Research also did a study last year. They're talking about the post-Snowden effect and enormous concern about surveillance. conducted by both government and businesses. And there was an enormous fear. 91% feared that they lost control over their personal information and that they were very concerned about surveillance. I'm giving you this just to give you an idea that people are very concerned about the use of their personal information, especially their health information. But I've seen this again and again. I speak to lots of organizations, especially in healthcare. When you explain to them that the use of their data for research purposes will be exponentially high, but that can be achieved without risk of privacy infraction, that their privacy can be preserved, strongly preserved, while their data can be used for these wonderful purposes. Everyone agrees to that. They don't have a problem with that. Their concern is when people say, we're going to use your data and forget about, stop worrying about your privacy, don't be selfish, don't care about that. That is the wrong approach because they have every right to care about their privacy. But you can show them that you can have privacy protection and health research being achieved, both objectives, and the huge majority will agree to that. Now, I'm trying to recall now why I have the next two slides, and I believe it's because when we were speaking earlier in the planning session, I think I was told that there are some members of the audience listening to this who are in the area of the smart grid. And if I got that wrong, please forgive me. So indulge me in the next two slides which deal with the smart grid, and it's all about privacy in the smart grid and how much you can actually give up in terms of the data linkage of personally identifiable information with detailed energy use, activities taking place in your home, and now we can connect this with cars that are going to be connected cars and electrically charged, and there's so much information about you that can be revealed. I put this out just to give you a caution that when we look at can the smart grid know too much, that the answer is yes, it can, but once again, there we can protect the data, protect the personally identifiable data through encryption techniques and anonymization techniques and a whole host of other things. So these procedures involving privacy by design can be applied widely across many different areas. Let me wrap it up by just asking you to consider the principles of privacy by design, embedding it into mobile healthcare devices and databases for use for research. The focus of PBD is always on prevention and building in the necessary protections before we use the data. And in the context of the health research that Dr. Alimam is about to discuss with you, really the only place to do it is up front at the design stage, where you can employ his excellent methods for de-identifying data without fear of privacy disasters arising, and rest assured that the data are being used to their maximum value, benefiting all members of society as well as the individuals involved without risk to their privacy. That, to me, is the ultimate win-win. Thank you very much.
Thank you very much. A great presentation, really a really great overview of some of the issues. One of the questions that or a couple of the questions were sort of similar in that the audience is asking, with things like the new Apple Watch, the research kit, which was in the latest version of the Apple phone operating system, the health kit, so the ability for these devices to collect what is health information for research purposes, or to access health information through connecting with electronic health records, etc. When you go from a heavily regulated industry like healthcare, and that sort of understands the implications of these and the regulations around it, to sort of private companies like Apple getting involved, how does that affect the individual's ability to sort of manage? You sort of started by saying, that this information self-determination. How is that going to affect the landscape of health information and privacy going forward, having these consumer devices that are now submitting and collecting health information?
So I think it's really, I'm delighted that people are asking those questions, because it's always, buyer beware, and there is, unfortunately, some responsibility that has to be taken by individuals at the beginning of the development of these technologies to ask the right questions. Apple is actually very respectful of privacy, and they're building in a lot of privacy-preserving methodologies, and they embrace privacy by design, so they care deeply about privacy. You may have been following the debate with respect to the the NSA, the FBI, and Prime Minister Cameron. They want back doors to encrypted communications. Apple has been one of the leaders. Apple and Google, they're leading the charge on saying, no, we encrypt all the communications through our devices, and we're not going to give you back doors. So, but that doesn't mean that you shouldn't ask those questions, because really, like, I don't know much about for example, the Fitbit. So everybody seems to be embracing the Fitbit. Everybody's got one, and it records, how many steps you take, and certain inferences may be made on that basis. I did an interview yesterday with someone who was asking about, what about employers? Can employers, a lot of employers are giving their employees Fitbits through their workplace health programs, and that's great. They're getting free Fitbits. But the first question they should be asking is, who gets access to the data? Does the employer assume that they are permitted to access the health data, and is the health data emanating from the Fitbit in any way being communicated wirelessly to them? And these are the questions that everyone has to ask at the beginning, because if everyone asks these questions, the people who are producing these products are saying, oh yeah, I guess consumers care about this, and they will rise to the top. So certainly now, at this initial stage, we cannot assume that the majority of these products can only be accessed, the data, by the individual, which should cause some alarm. I'm working to talk to a lot of these companies and trying to get some protections where privacy is the default, and the people making use of these products can be given that kind of privacy assurance. But don't assume that that's the case now. Ask questions anytime you get involved in any of these connected devices.
All right, thank you. And we had another comment about the person is suggesting that there's often the comment made that the individual isn't capable of understanding the risks. Even though it is their information and they own it, they're not capable of understanding the risks. So in many cases, the healthcare system feels obligated to protect them from themselves, so to speak. Is that sort of true, that institutions often prevent people from accessing what is really their own information because they don't feel that patients and families, particularly children, and for this audience, the pediatric community, in understanding the implications of accessing their own information?
I just think that's so patronizing a view on the part of hospitals or healthcare providers. So it's not that I disagree necessarily that patients may not be able to understand all the risks, but the point is the data is the subject's data, the data subjects, the patient's data. And access to your data, health data, so in Ontario, for example, we have PHIPA, the Personal Health Information Protection Act. You have a right of access to your health data. The hospital or healthcare provider can't tell you you can't access your data because they're worried about what you're going to do with it or whatever. So I think that is an inappropriate paternalistic view. Now, if you as a healthcare provider want to discuss the data with the patient before you give it to them and explain whatever it is you'd like to, absolutely, that's a great thing to do. But you can't assume that the patient is clueless in this area. Especially, I wasn't going to bring up Edward Snowden, but I have found that ever since Edward Snowden's revelations, there has been such an increased concern and understanding of privacy issues on the part of individuals across the board. And so accessing your health data, and I can tell you as someone who's been a patient for many, many years, I always make sure I have copies of the latest MRI, the latest scans, or whatever the test results are, so that I have a full copy of everything. Because you go to multiple doctors and they don't have copies of everything. You are responsible, in a way, to ensure that you have access, you have everything. You have all your records, and you can share them with other healthcare providers, etc. So, I mean, I reject that model of the individuals aren't responsible or don't know, not to suggest that they need to be knowledgeable in this area, but they have a right of access to their own information.
All right, thank you very much for that. All right, but if there's any other questions from the audience, please do type them in, and we can certainly get them after this next segment of the presentation. But it's now our pleasure to hand the virtual podium back over to Dr. Khaled El-Imam.
All right, perfect, thank you. I will then continue along the same lines by giving you a little bit more details on the identification methods and how these work in practice. And this will be a high-level overview, just to give you kind of a flavor of When you have a database that's going to be used for some of these observational studies that I mentioned earlier on, or is going to be used to learn from previous patient experiences, the database needs to be identified, and so we give you some of the basic principles of how to do that. So just a point on consent. I brought that up before. If the data is identified, there's no requirement to obtain patient consent if you're going to use the data for secondary purposes, such as the learning health system example that I mentioned. In Ontario and other jurisdictions, the identification is a permitted use. It means that as a data custodian, you're permitted to de-identify the data without obtaining consent for de-identification. If the data is being collected, so some of these databases or integrated databases, when they're being created, the data is collected from vendors. So these could be vendors of the electronic medical record system or the pharmacy system. There may be contractual considerations that are overlay on top of the legislative requirements. So these have to be considered. But in general, if the data is de-identified, then we remove the requirement to obtain upfront consent for using data for these purposes, and most research ethics boards would support that view as well, should this go through an REB. So I'll describe you the series of de-identification methods that have been found acceptable to be acceptable by regulators. And also, I mean, we've been doing this for more than a decade now, and there's been audits, investigation, and also litigation. So I would argue it's passed a number of tests. And also, there are a number of now standards that have been published that implement the process, the identification process that I'm going to describe. This is consistent with existing standards today. And just a key point here is that in most jurisdictions, the definition of anonymized or de-identified data follows a reasonableness standard. So it's not a perfection. There's no expectation that there's zero risk or that it's impossible to identify individuals in a data set. It just means that it's not likely. It's not reasonable that someone can be identified in the data set. And reasonableness includes, typically interpreted to include things like effort and resources and skills, as well as technical capabilities to identify an individual. So we'll cover some of those elements as well. So here are some of the recent standards that have been published that describe the identification methods. They're all somewhat consistent with in terms of what they describe on how to de-identify data. And they all follow risk-based approaches for the identification, which is what I will describe. So the first one is an Institute of Medicine or National Academies of Science in the U.S. report on clinical trials data, but there's a de-identification appendix, and that is a general appendix. It can be used to identify any type of health data. The next one is the Council of Canadian Academies, which at the end of March of this year published a report on sharing health data for research purposes, and there's a description of a de-identification process as well. HITRUST is an industry consortium that publishes standards for protecting health information, and they publish a de-identification framework standard as well. And then the other ones are, one is from Health and Human Services in the U.S., the regulator, one is from the regulator in the UK, and then the FEW standard is a pharmaceutical industry standard for de-identifying clinical trials. All of these are consistent with each other, so there are strong, consistent standards on this topic. I've also published 3 books on the topic, which provide methodology, theory, and practical guidance as well on how to de-identify data. So there's a lot of material specific to health data that's been packaged and made more applied that can be used in practice. So this is doable and is current practice now, using these methods and approaches. Okay, so let's talk about some of the basic principles of de-identification. So as I mentioned, anonymization or de-identification, I'll use those two terms interchangeably, as a risk management exercise, which means that it's not only about the data, it's about the context of the data release, and how the data is being shared. The risk-based approach means that you measure the risk quantitatively, so it's a very quantitative process. As I mentioned, the context is taken into account, and the process is evidence-based as well. So it's based on a large body of literature in the disclosure control community. There are two typical ways that data can be released or shared. There's microdata release, where individual level, patient level or participant level data is shared as a file, as a data file, a SAS file, or a database file. If you go to Statistics Canada and get their data, they'll give you a file, for example, and that introduces a set of issues around identifiability and protecting the data. Another approach that's more commonly being used now is creating an online portal. The data users don't get access to the data, but they get direct access to the data. I mean, they don't get a data file, but they access it through a portal, and they're not allowed to download or copy the data themselves. They only view it in this read-only portal, which puts some limitations on what they can do and kind of queries they can run on the data, and all the queries are monitored. So if someone is misbehaving, then the audit tools and the monitoring tools would catch that. So these are the two typical ways for making data available for analysis purposes, whether it's research or doing these find a similar patient type scenarios. It's important to keep in mind that protecting privacy and data utility are two dimensions that need to be optimized. There's a trade-off here. So if you want maximum privacy, then there's no data utility, because you basically don't share or make any data available. But if you want maximum utility, then you remove all privacy restrictions. So neither of these two endpoints are desirable. Therefore, there's a balancing act between those two. You try to protect privacy to some extent, but maintain data quality and data utility as much as possible, so the data is useful at the end of the day. Because whenever you de-identify or anonymize data, you have to apply some modifications to the data. For example, you can take a date of birth and convert it to a year of birth, so you lose some information there. So there's a balance between how much information you lose versus the quality or the utility of the data. So when we talk about a data release context or a data sharing context, which is important for deciding how to de-identify the data, we look at three things. So we look at who's going to access the data, who the data recipients are, what kind of security and privacy controls they have in place, what capacity they have to re-identify individuals, and whether they have the motives to do so. And there can be very precise questions that can be asked around these three elements. And then there's contracts or agreements that the data users need to sign, and what kind of clauses or controls are in these contracts, which is also another element of this risk assessment. And then we look at the data, the sensitivity of the data, the consent, and the potential harm if the data set was re-identified. So the characterizing the data recipient, the contractual controls, and the data itself are the three elements of the data release context, which determine how much we need to de-identify the data. So if you're giving, as an example, a SAS file to a researcher who's going to do a comparative effectiveness study of some sort, then you'd ask questions about what kind of controls, security and privacy controls, that researcher is going to have in place in their lab. You'd have questions about the contract that's in place, data use or data sharing agreement with that researcher, what kind of prohibitions are included in there, and then questions around the sensitivity of the data. So that's the context. Now let's look at the data itself. And in a typical data set, there are direct and quasi-identifiers. That's how we classify the variables in the data. So direct identifiers are variables in the data set that can directly identify individuals, such as the name, address, telephone number, fax number, medical record number, email addresses, any kind of biometric or photographs, and so on. And typically for the purposes of a learning health system or the examples we looked at, you would typically don't want to have that information in there. You don't need to know who the individuals are, because basically everything we're talking about is analytics on the data. So knowing the identity of the individuals is not important to answer the questions that need to be answered. So typically for the cases we were looking at, most of the direct identifiers are removed, and you just maintain a pseudonym that will allow you to link all the records that belong to the same patient. But you just remove the names and addresses, etc., as the first step in de-identification. Then you have all the quasi-identifiers, which are the other pieces of information that can be used to re-identify individuals in a data set. And this is really important. So you have demographics, socioeconomic status information, dates and location information, and also rare diseases, rare diagnoses, which are visible, can also identify individuals. And so just getting rid of the direct identifiers is not sufficient. You also have to deal with these quasi-identifiers. And all known re-identification attacks were done on these quasi-identifiers. So this is why you need to deal with them. It doesn't mean you have to remove them. It just means you have to account for them and maybe perturb them a little bit. So this is an example of a re-identification attack. So there have been a number of re-identification attacks. I'd say about 20 so far. Roughly half of them are on health data, and the other half are on other kinds of data. And re-identification attacks are done by mostly academics and the media, reporters and broadcasters. So this example was done on the State of Washington Hospital Discharge Database. And in this case, the researchers took newspaper articles with vehicle accidents and domestic disturbance stories and matched that with the hospital discharge database, which at the time the state was sharing for the purposes of research and public health analysis. So the researchers were able to re-identify individuals using the information in the newspaper articles. And so here's an example of Raymond Boylston, who's a 61-year-old gentleman who had an accident on his Harley. So we have the date of the accident, we have his age, we have his name. By matching it with public records, such as the white pages, we were able to get his zip code, and then we know which hospital he went to, and we know that he had a broken pelvis, which was mentioned in another part of the article. So we know the diagnosis. So with that information, it was possible to exactly identify which record in the hospital discharge database belonged to Raymond. And he was gracious enough to allow the Bloomberg News to actually tell his story in their article. But that's a classic example of a re-identification attack. And there are examples in Canada as well. The CBC did one with the Health Canada Adverse Drug Event Database, and there was a federal court case around that. So there are Canadian examples, American examples, European examples. I mean, these things have happened. All of these re-identification attacks that were successful were done on the quasi-identifiers. So in those cases, the attackers only used quasi-identifier information. No names were in the data. There were no addresses, no telephone numbers, so they used the quasi-identifier information to match records with some other information to figure out the identity of the individuals. So you have to take care of both direct and quasi-identifiers. In a Canadian context, just to illustrate the risks, so we did a study a few years ago with records from the RAMQs in Quebec. So this is for 1 million Montrealers. So we looked at basic demographics. We did this work with our colleagues at McGill. So just give you quick results here. The x-axis here, the number of characters in the postal code, and the y-axis is uniqueness, how unique individuals are on the island of Montreal. We looked at what the basic demographics, how they make individuals unique. So across all individuals, the 1 million individuals that we used to estimate for all 4 million on the island, if you have a 6-character postal code and full date of birth, about 96% of individuals are unique. And if you only look at adults, it's about 99%. If you look at youth and adults, it's about 96%. So Canadians are unique essentially on their 6-character postal code and date of birth. Exactly the same study was replicated in Alberta. Alberta Health Services did a similar analysis on their population registry, and that's 99% of the population of Alberta is unique on their date of birth and postal code. And this is the kind of information that's publicly available or can be found. So if I see a date of birth and a postal code in a data set, these are examples of quasi-identifiers, and it matches my neighbor, I'm almost certain that's my neighbor because it's a unique identifier. So what's interesting is if you keep the full date of birth and you reduce the postal code to 3 characters, there's still about 80% of the population is unique. So uniqueness is still high. But if we remove the or generalize the date of birth to year of birth, then with a 6-character postal code, we're around 65% unique. But with a 3-character postal code and year of birth, it's 0, almost 0. So by manipulating the granularity of the data, you can manipulate the risk. Uniqueness is one measure of risk. It's not the only measure. There are better measures than uniqueness, but it's a basic way of looking at how easy it is to identify individuals if they're unique in the population. So you can manipulate that by playing around with or modifying, generalizing the detail. In this case, we generalize the postal code. If we generalize the postal code to 3 characters and date of birth to year, we can achieve 0 risk. And the green line here is a longitudinal data set, so we looked at individuals over time. And always longitudinal data, when you look at a pattern of visits, for example, for a patient over time, the risk is always going to be higher because you have more information about the individual. So you have information about their visits, you have more information about their health condition, their diagnosis, their procedures, and depending on if you have pharmacy data, then you have information about the drugs that were prescribed or that were dispensed to them. And then if you have community data or GP data as well, then you have information about what happened in the community. So longitudinal data is always going to be a higher risk than cross-sectional data, irrespective of what other information you have. So it's not only, I mean, the example here was date of birth and postal code, but it's not only those two. It's any quasi-identifier in the data set and any combination of them. So here's a simple data set of date of birth, date of admission, location, and sex, which is one of the data sets we worked with. And on the right-hand side is a probability of re-identification. Just a probability between 0 and 1. So in this case, if you have those 4 pieces of information, the date of birth, date of admission, location, which in this case was a postal code, and sex, then the risk of re-identifying individuals was 1 because everybody in that data set was unique. But if you reduce the variables in the data set, so you look at 1 or 2 or 3 subsets, basically the risk can go down, can go lower. So the more information you have in a data set, the more of these quasi-identifiers, the higher the risk is going to be. And if you have dates and location information, postal codes, you're going to reach a risk of 1. This is almost certainty of identification pretty quickly. So what you typically do then is reduce the precision in the data by reducing the date of birth to year, to a 5-year interval, to other types of intervals. You can change the date of admission to month and year or quarter year, and then you can generalize the location as well. So by playing around or manipulating the granularity of the variables, you can start manipulating the probability of re-identification, which is the value on the right-hand side. And you can reach a level of detail in the data set that has an acceptable probability. And there's a way or a process to determine exactly what acceptable probability is. So I'll give you just a quick example. So one example of these databases is the real-world evidence database. It's an electronic medical record for about 600,000 individuals that for family doctors and walk-in clinics that was analyzed to support learning health systems. And so that data was de-identified, and one of the analyses we did was to look at how does de-identification affect the conclusion of the analysis that you do on the data set. So this is a post-marketing surveillance or adverse drug event type analysis. So we looked at, there were 2 arms in this protocol, and one arm were patients who were prescribed NSAIDs, and second, this arm 1, arm 2 were prescribed NSAIDs and PPIs within a certain period of time, and the patients were matched. And then we looked at a series of codes for adverse GI events. So did the patients come back later on within the year with adverse events, GI events? So then we could determine if there was a temporal relationship between the prescription and GI events. And so these are just the counts. You can see for arm 1, before the identification, there were 73 patients who had GI events in arm 1, and after the identification was 78, and then in arm 2 was 8, and 8 wasn't, the numbers weren't affected. So this is typical from what you see with the identification, is that the exact numbers will be slightly different, but the conclusions are, if the identification is done well, the conclusions are not going to be affected. And then another example, this is a public health surveillance type scenario, so it's looking at chlamydia surveillance. The Public Health Agency published chlamydia screening guidelines, and they had no baseline for how much screening was going on. So this database was used to determine the baseline screening levels before the introduction of the guidelines for females between 14 and 24. Screening before was 4.8% on the original data, and was 4.8% on the de-identified data. And then the positivity, this is for 2013, and the positivity for those who were screened was 9.7 and 10% before and after de-identification. So that's kind of the impact you expect to see with de-identification, small modifications in the numbers, but I haven't seen yet an example where the actual conclusions of the analysis have been affected, assuming that you've utilized a good and defensible de-identification protocol. So I'll leave it at that. I mean, I know this is a very high-level description, but it gives you a sense of the kinds of things that are doable, and the general approaches that are available to create these databases. I'll leave it at that. Thank you.
All right. Thank you very much. While we're waiting for any questions to come in from the audience, one of the questions that we're always confronted with at CAFC here is around sort of aggregate data that the health centers want to share, pulling data from CHI and that sort of example. And there's often this conception that all of that sort of aggregate health data falls under the same rules that you're describing here around patient record level data, in their willingness to share and their willingness to use cloud-based tools for analyzing data and that sort of thing. I was just wondering if you could comment on that as far as the kind of things that you're talking about in personally identified data versus aggregate health information that a hospital might want to share.
Right. Well, it depends on what you mean by aggregate, because if just by labeling it aggregate doesn't remove the risk. So if aggregate tables are counts, then counts can always be converted to individual level data. So if the risk is small on the individual level version of that data set, then the risk will be small on the table or the aggregate version of that data set. Just because it's aggregate doesn't mean that it gets a free pass. Although I see that happening a lot as well, is data is converted to a tabular form, and it's labeled aggregate, and then there is less concern about the privacy issues pertaining to that data, which may not be the right decision. So as a general rule, count data are the same as individual level data. My recommendation is to identify the individual level data and then release as many count tables as you want. If you're going to do some more sophisticated aggregations or summaries or descriptive statistics, it will depend on that. For example, if you're releasing averages and the variation around the averages are very small, then you're essentially releasing the original values. So there are a number of considerations here. It's not straightforward. So one, it doesn't mean you can't do it. You just need to have some protocols in place to de-identify the data before you create those aggregate tables.
All right. Thank you. Yes, it just goes to show that it's complicated no matter what level you're looking at. There's always lots of angles that need to be approached here.
Well, I mean, there are good ways to do this. You just have to, whoever is doing this has to be educated about the issues and implement protocols to deal with them. So it's not necessarily complicated, but there's some education that's needed in order to implement those protocols.
All right. Julia put in, I think she's got half a question in. She's made a reference to your slide around risk measurement example, but I think the rest of the question is coming in. So she's talking about your slide where you talked about the risk measurement example, and she says, do you have a probability of re-identification if year of birth and location is provided?
Yeah, I mean, If it's only those two pieces of information, so I mean, we said there's a number of different things that are considered quasi-identifiers. So you have to consider all the quasi-identifiers in your data. But if these are the only two quasi-identifiers in your data, the year of birth and the location, which would be a 6-digit postal code, I think. Let me pull up. I mean, it's in the. I think that's in the chart actually. So that was about 65% for urban areas. I mean, we used Montreal as an example here, but I'm comfortable generalizing that to other urban areas across the countries. For rural areas, it's slightly different. But a 65% uniqueness. So 6-digit code, postal code, and year of birth, which is still high. That's a high level of uniqueness. Postal codes are very revealing because the median is about 20 people who live in a postal code. So there's not many people in a postal code, and if you put in an age or a date of birth, that really singles them out quite effectively. So generally speaking, detailed postal code information will be highly identifying. Generally, you'd reduce the geography to manage that risk.
All right, thank you. Great question. All right, any other questions from the audience before we move on?
One of the things that came up before the webinar that someone mentioned to me was around image data and de-identifying images. So let me touch upon that. There are good ways to de-identify images as well. There are standard file formats for images, and typically there's PHI embedded within those files, and there are good ways to deal with those risks. And then if the name of the patient is part of the image itself, there are blurring techniques that can run on the image and blur the text in the image. And then if the image is of a face, there are also techniques that will detect facial features in an image and blur the face as well. So for different types of images, there are tools and techniques to deal with re-identification risks there. They're a bit more involved than what I described here, but they exist, and again, that's a solved problem. So if you're sharing images and you want to de-identify them, then I can point you to some resources that can help with that. The only thing that cannot be really de-identified properly is genomic data. And there are no good solutions for that. So sharing genomic data requires special precautions. But otherwise, for clinical, administrative, or survey data, and image data, there are good ways to address those risks and share and make available these pooled repositories with defensible protections around them.
Mm-hmm. All right, great. That's very good to know. And when you talk about image data, you're talking about images of people's faces. Typically, you're not talking about diagnostic imaging.
No, I mean, for diagnostic imaging, you also have embedded in the files, you'll have the patient name, the medical record number. There may be part of the report or some narrative embedded within the files as well. So these are DICOM files, which have a lot of information embedded within them. It's not visible. It's part of the digital content of the file. So you need tools to go in those files and extract that information, because the machines that produce those images embed a lot of information within those electronic files.
All right, good to know. All right, well, I don't see any other questions coming in, and we are just about out of time. We've got about 10 minutes left, but if there are any last-minute questions that people have their fingers flying on the keyboard to put in, please do. But while we're waiting for that, perhaps we'll just take maybe some closing comments, maybe starting with Dr. Ann Kavukian. Maybe we could hear, any closing thoughts you'd like to wrap this session up with.
Thank you very much. I just want to point to the absolute vital need to continue health research in so many different ways. This is a living health system. There are all kinds of different manners in which research will enable wonderful outcomes. We can and must do research in concert with protection of the data. The methodologies that Dr. Alamam has pointed out show that this is eminently doable. So what I want you to do is reject any messaging you hear that well, we can't do research because we need to protect people's privacy. No one is a stronger proponent of privacy than I can assure you. But what I know is that that is a false message, because you can protect privacy very strongly and also ensure that research can be conducted. You can have this win-win proposition. So next time you hear this zero-sum model, blast it out of the ground, and you can send them to me if you want. But just let's get that messaging out that you can indeed have both. Thank you.
All right. That sounds like a threat, but I think it's a good one. All right. And we don't have any more questions, so Dr. Khaled El-Imam, perhaps some closing comments from you. And thanks again for helping us organize this and for connecting us with Dr. Kavoukian. That was great. So any closing comments from yourself?
Yes, I mean, I would just say that everything I've presented has been implemented, and the real-world examples of these learning health systems being set up, real-world evidence databases being set up that can be used for the scenarios that I described. This is achievable. It's practical, and the trade-offs between privacy and getting access to the data have been analyzed and have been managed. So it's not an either-or. You just need to have the appropriate skills and education to implement those methods and techniques, and then you can start getting access to those types of data. And the vendors who have so the vendors of electronic medical record systems and the various software and systems that collect this data at the various facilities are also becoming very supportive of facilitating the sharing of that data. There's a realization that this data is useful, and there's more interest in facilitating the sharing and getting access to this data. So the environment is becoming more conducive to sharing data. And so the privacy issues can be solved and the data can be shared.
All right. Well, thank you very much. Such a great topic, and so many things that we could do if we start sharing this information and collecting it and putting all the pieces together across the country at our various institutions. So really a great start to this conversation. I hope this conversation continues, and I hope everyone found something useful today that they can take back to their own organizations and start doing feeling more comfortable that there are resources out there to help them in their quest to sort of collaborate on research projects and other things. So thank you to both Dr. Ann Kavoukian and Dr. Khaled El-Imam. Great presentation. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great, as you can see, if you can watch live, as your questions and comments really enrich the discussion. But if you can't watch live, as I mentioned at the beginning, we do record these sessions. Please let your friends and colleagues know they're welcome to watch the sessions as well if they weren't able to join you. So we do have a great lineup of webinars for the next couple of weeks. Next week we'll be hearing from our colleagues from Holland Bloorview talking about using technology to transform care, engaging and activating families in the implementation of a health portal. And they'll be talking about their Connect to Care portal, which provides patients and families with access to their health information, certainly related to the topic that we're talking about today, giving patients access to their personal health information. And this sort of was spurred by our presentation a few months ago, where we had our colleagues at CHIO talking about the MyChart at CHIO project, where they were doing something similar and creating a patient portal to access their health information. So it'll be a great opportunity to hear from our colleagues at Holland Bloorview about how this might be a slightly different in a rehab facility context. And following that, we have a session called Challenges in Remote Air Medical Transport. And this topic comes to us from CAFC's Interfacility Transport Committee, where that's the committee where we discuss standards and other issues around neonatal and pediatric interfacility critical care transport. And we'll be hearing from Penny Triggs from Keewatin Air out of Manitoba and Cara Levy from Advanced Medical Solutions and Medic North. Both are great colleagues with extensive experience in providing services to remote communities in Canada's north. And they have assured me that there will be some very interesting and potentially even hair-raising stories they're going to share with us about providing services in our remote communities in the north. So some great stuff coming up in the next few weeks. Thanks for joining us today. Thank you again to our speakers, and we hope to see you back here next week. So thanks, everyone. Bye.